we are a small group in the meeting room, but we have a lot of our colleagues, 50 now, on a virtual basis.
Oh, that's excellent.
I'm Dr. Faye Ghalib. I am the head of the clinical laboratories and the chair of the scientific committee. On behalf of the CEO, Professor Dr. Hani Hussein, I welcome you and thank you very much for your time and expertise.
Thank you. Okay, so shall I begin? Yeah, I will share my screen now to show my presentation. Okay. So, first of all, I'd like to thank... First of all, I'd like to thank you for your kind welcome. I'm Carsten Engel. I'm the CEO of ISQua, the International Society for Quality in Healthcare. I'm speaking to you from Denmark, where I'm based, whereas the ISQua office is actually in Dublin, Ireland. And again, thank you for the opportunity to speak to you today on the kind invitation of Dr. Bilal Ahmed Abdou, who is an individual member of ISQua. I did a little bit of research, and I found that I'm clearly speaking to people who take their commitment to delivering quality healthcare seriously. You are accredited by GAHA, and in addition, you are certified against ISO 9001 in 2023. In 2022, you even received a golden certificate as the first environmental friendly green hospital in Egypt. So you have embraced something we emphasize very much in ISQua. Sustainability is an integral part of quality. I noticed that Dr. Abdou and his colleague, Dr. Ghalib, even published the experience from accreditation in the American Journal of Clinical Pathology. And I quote, "Achieving GAHA accreditation had positive impact on laboratory workflow, staff professional development, compliance with guidelines, ensure reliable laboratory results, and overall laboratory performance. Laboratories should consider accreditation and implementing quality assurance measures to enhance the delivery of high-quality laboratory services and patient safety." I couldn't agree more. So congratulations on all of this, and I hope I can provide you with some further inspiration. But first, a few words about the organization I come from. ISQua is a non-profit organization dedicated to improving healthcare quality and safety worldwide, and we have been in existence for more than 30 years now, actually close to 40 years. We do this through education, knowledge sharing, and by supporting health systems. Our networks of healthcare professionals spans over 70 countries, including Egypt. We work under the tagline Knowledge, Network, Voice, Action. We are committed to gathering and disseminating knowledge through our network, through which we try to connect researchers and knowledge users such as yourself. We believe that it is important that the evidence produced by researchers is made available at the clinical front line and presented in a way that allows practitioners to use it to transform care. That's, at the end of the day, the ultimate purpose of research, to improve what we're doing, continuously improve what we're doing. We have members all over the world, and as an ISQua member, besides of being part of a network, membership gives you access to website content, discounts to conferences, and access to our peer-reviewed scientific journals. We also assist institutional members in finding speakers for education and events. Institutional members can enroll staff at a discounted rate in our online training program, the ISQua Fellowship, and I'll tell you a little bit more about the fellowship. The fellowship program is an affordable web-based learning program that enables you to learn from renowned experts where and when you have time for it. We currently offer 9 courses. Each is expected to take 20 to 30 hours to complete. If you sign up as a member of the ISQua Fellowship and complete 2 courses within the first year, you can call yourself ISQua Fellow. And if you maintain your fellowship by completing one course each following year, or join ISQUa's conference or other selected major international conferences, you can continue to call yourself an ISQua Fellow. We don't consider this to be an academic qualification. It is a learning community, a fellowship of learners where you strive to improve yourself by watching webinars and discussing with your fellow students. In addition to the 9 courses we currently have, we will add new courses, and this year we will add one on sustainability and one on artificial intelligence, 2 very timely additions. One of our major programs is the International Accreditation Program that's delivered by our sibling, the ISQua EEA. In the International Accreditation Program, we don't accredit healthcare providers. It's an accreditation program for healthcare accreditors like GAHA in Egypt. And GAHA currently holds all 3 accreditations offered by ISQua EEA, both standards accreditations for several sets of accreditation standards, and this certifies that the standards are developed in a rigorous process and address important quality issues. GAHA also has accreditation as an external evaluation organization, and that certifies the quality of the accreditation services it delivers. And finally, it holds accreditation of its surveyor training program. So the accreditation offered by GAHA is based on standards and a methodology that's aligned with international good practice. We publish with the Oxford University Press 2 peer-reviewed journals. The International Journal for Quality in Healthcare is recognized as a leading journal in the field, whereas the IJCOMS is a more recently established open access journal that partly functions as a waterfall journal for the older journal, but also publishes in its own right with an emphasis on implementation and on content of regional interest. One of the annual highlights for us is the international conference that circulates around all continents. This year we will meet soon, quite near to you actually, in Istanbul. And when we look a little bit forward, we will move to Sao Paulo in Brazil next year to continue to our home base, Dublin in Ireland, in 2026. It has already been decided that we will go to Vancouver, Canada in 2027, but after that the field is still open. So just to present a few highlights from the conference, and a lot happens, and it's really a good place to come together and meet fellow quality people. But now I'll move on to my topic for today. I will begin with some general considerations on patient safety and then move on to diagnostic safety in particular. Patient safety begins and ends where the patient meets the healthcare professional team. But let's begin by first zooming out and taking a look at the entire system. We know that healthcare is not a simple system, but in what way is it not simple? Is it like a complicated machine that we can design and describe in all detail and that works in a predictable way once it's put into action? Is that the case? No. One of the remarkable things about healthcare is that it is a highly complex system, which is more than just complicated. Some consider healthcare to be the most complex system ever created by humans. We have probably an intuitive sense of what we mean by the word complex. But what I want to introduce to you today is some ideas about what causes complexity and some of its consequences for the way in which we should think about patient safety, among other things. Healthcare is a complex adaptive systems. That means that relations between causes and effects are not linear, but include positive and negative feedback loops and crosslinks between different processes. That means that the effect of a given action can't always be predicted precisely. What we do at one point may have unexpected consequences at another point once it has passed through all the feedback loops and cross links. And that again means that the system can't be understood by just understanding all of its components. It has what we could call emergent properties. It's also important to understand that the system is not closed. It has an open boundary. It interacts with its surroundings, and these surroundings are not controllable from within the system. And it also importantly evolves over time. Now, we want a healthcare system that's able to perform as expected under varying and partly unpredictable conditions. If you work in a busy emergency ward or in any business hospital unit, you will know that we can't always predict what will happen in the next moment. And a system that's able to perform as expected under such conditions is what we call a resilient system. The circle to the right side of this slide illustrates a fundamental process that allows a system to be resilient. First, sitting within the system, we must anticipate. We must have some ideas about what might happen. And this also includes that we must understand what we have to look for to monitor whether things are progressing as expected, or if you need perhaps to adjust or intervene. We must need to have a set of actions, a toolbox, if you like, from which we can build a response once we have monitored that we need to do something. And we must have the insight to learn from your experience, to improve your skills and your understanding of the system, improve your toolbox, improve your anticipation, improve your monitoring. This is one of the mechanisms by which a complex system becomes a learning system. It can learn and adapt from experience. And one of the important aspects of leadership is to support, nurture, and empower to make this happen, or in other words, to support a learning culture. The culture is important as you can't design a complex system completely top-down. You need even to encourage local adaptations and adaptations over time as conditions change and things happen. So any deliberate effort to change healthcare delivery must be based on 3 pillars. Obviously, there must be a rationale in health science for the change. But in addition, you must leverage implementation science. There's a difference between understanding what we want to change and understanding how we can make that happen. With a background in science, you might think that good arguments convincing that the thing is a good thing win the day. And you will probably have experienced that this is not always the case. Implementation science is important to understand because it teaches you what it takes to make people change their beliefs, their habits, and their power games. In other words, what it takes to make them do the thing, not just intellectually accept that it is a good thing, but also actually do it. In a complex system, what a healthcare professional leader brings to the table is not so much knowledge about the thing, but an insight in how the system works that can help him or her to understand and take the system's perspective and ask the right questions to facilitate change. Here you can see the same triad in some other words. We need to know what is effective. It is important that we not only consider the what, but the actions, but also the how, the mechanisms by which the actions generate the effect. Otherwise, we may miss the point of the success story and we won't be able to adapt the intervention we want to implement. We won't be able to adapt it wisely to our own system environment if we don't understand the way in which it operates. It operates. In addition, we must of course consider how we can make people change their behavior, and we must take the systems perspective, meaning we must ask ourselves how will the change affect other processes to avoid bad surprises and perhaps still be prepared that surprises may occur, and we'll have to monitor, anticipate, monitor, and respond. So a pathway to successful implementation, and this will include any implementation, includes implementation of more safe procedures, is like this. You will notice that this is very similar to the model for improvement that is promoted, for instance, by ISQua. So, yeah. First, you must clarify the change and the rationale for it. And you must understand deeply what it is you want to implement. Just copy blindly the superficial evidence you have seen in other places. I could tell you a story about the surgical checklist to illustrate that. You must also analyze barriers and facilitators and select an implementation strategy. And you must monitor the implementation by data collection, and you must reflect on the data you collect. And this reflection you must do not just to see if you achieved what you intended to achieve, but you must also understand how and why you achieved what you achieved. And lastly, the insight you gain during all of these exercises will feed back to the way in which you understand the what and the how and the implementation strategies in a series of cycles. And this is, of course, the same as the PDSA cycle, Plan, Do, Study, Act cycle, that is probably well known to you. So now I will zoom in again and look at the system in more detail to understand better how it works. There's a method called the FRAM methodology, the Functional Resonance Analysis method. It offers you an opportunity to model a complex system and understand how the activities or functions within this complex system, how they are connected. At the center, you have one activity or a function. It processes something that comes in, the input, to generate something that comes out, the output. There may be some preconditions that may have to be met before the activity can be initiated, and there may be time constraints. You may need some resources that may be the output of another activity to enable to perform the activity or function, and there may be controls in place to monitor or control the activity. The output may be the input or a precondition or a resource for another activity. You can use this method to formally model and analyze complex processes. And if you use it to model clinical processes, you can use it at different levels. You could analyze the care process for a cancer patient and consider surgery to be one of the activities on the journey. But obviously, the process of preparations and anesthesia and surgery and post-operative recovery could itself be broken down into a complex network of activities. So you can imagine that even a comparably simple process such as medication reconciliation, you check the medication a patient that's on the patient's medication list with the information you have about previous medication, what the patient actually takes. Even a simple process like that, if you put this into a model like this, it turns out that it's more complicated and you understand better why it doesn't always work as well as you would have expected it to. There's a difference between what is effective what can work under optimal conditions, and what is efficient, what can works under actual conditions. To add to the complexity, the FRAM model is not, when you apply it to healthcare, is not connecting a series of mechanic processes. At the center of each activity, there are actors. Actors have skills, they have judgment, they have tools and agency, and you will notice that an actor needs a lot of skills and knowledge to be able to perform the anticipate, monitor, respond, learn cycle in a appropriate way. They base their decision on their situational awareness. What is the situation like now? And they base them on, in addition to the knowledge they have, they also base it on the aims, the values, and the rules as they perceive them. Where it often will be the case that the rules embedded in culture, how do we do things here, are stronger than the formalized rules written down in policies and procedures. The actors will be able to see and make sense of what's going on locally, but no actor, including the top management, has a detailed understanding of the entire system. Actors can't act sensibly without understanding what's going on around them, and in fact, they may create their own understanding if none is offered to get things to make sense. Another perspective. The two researchers, Vincent and Amalberti from England and France, they studied safety and found that system can take three different approaches. Systems can take three different approaches to safety. These approaches reflect different degrees of complexity, from the highly complex ultra-adaptive domain to the linear and predictable ultra-safe domain. At one end of the spectrum, we have the ultra-safe domain, where couplings are largely linear and things therefore predictable. Risks can be avoided by applying rules based on insights into how things work, what they call powered regulators and supervision. Training is in teams. At the opposite end, we have the ultra-adaptive domain, highly complex. Risk is embraced. We deliberately take risks because the gains we hope for outweigh the risk. But we are not reckless. We take risks, but we are not reckless. And this is domain of power to expert. Training is mainly training of individuals, although we will acknowledge that these individuals typically work in teams. And in the middle, we have the domain of high reliability. It's still complex enough to make risk elimination unrealistic. Unexpected things can and will happen reasonably regularly, but the risk can be managed. And here, well-trained teams are again essential. A substantial proportion of healthcare activities, possibly most, fall in these domains, but it's of course important to realize when you are in one of the other domains, and in particular to make that ultra-safe that can be made ultra-safe. Now let's zoom out again to consider what a leader can do to support and improve performance. Leaders can modify the hard components of the system and the formal rules, but more importantly, they can influence the behavior, expectations, and belief of the actors. They can support them in requiring and improving their skills, judgment, and tools. They can promote team performance, and importantly, they can make sure that aims are aligned across the situation, the system. If people in different parts of the system works guided by differing or perhaps even contrasting aims, that calls for trouble. Prudent standardization can help you. You should identify the activities that can be moved into the ultra-safe domain, and you should establish useful, flexible routines in the other domains. That's what I call the toolbox for resilient performance. The aim is to reduce complexity by increasing predictability, not to capture performance into rules. And you should note that how to is often better standardized than when to. It's not always easy to standardize exactly when a certain procedure should perform, but you can very often benefit from standardizing how it is performed when it is performed in the initial steps. One encouraging consequence of complexity is that rare events resulting in serious harm are usually not caused by very special causes, but by common causes, acting in a specific configuration of the system. One model of a complex system you can use as a kind of metaphor. Think of a pile of sand grains, dry or almost dry sand grains. They lie there as a little mountain. You drop one other sand grain onto the pile. Sometimes nothing happens, it just comes to rest. At other points, a little avalanche results, but every now and then a big avalanche will occur and the pile will collapse. This is not due to any difference in the sand grain or the way it was dropped, but it depends on which configuration it drops into. You can explain the avalanches all the time, but you cannot predict an avalanche but just by considering the system locally, because there can be distant effects in play as well, and you need to understand the entire system. What this means is that we can learn from near misses and from studying what goes well, because these are the same processes that from time to time collude in a way to create great and very consequential adverse events. Okay, now over to diagnostic safety. Diagnostic safety is a major problem, and it is very well reasoned that the WHO made diagnostic safety the topic of today's this year's World Patient Safety Day. We have some data from the US, and we would find similar data in any other country, I'm sure. But you can see the impact: 800,000 deaths or permanent disabilities annually in the US. That's really something. But we also know a little bit more about it. We know, for instance, that the big three dangerous conditions are infections, vascular conditions, and cancer. And the top, and these are the big three condition categories, groups of conditions. And when you look to conditions in more detail, you will see that the top 5 conditions account for close to 2/5 of the total serious harm. And these top 5 conditions are stroke, sepsis, pneumonia, venous thromboembolism, and lung cancer. These are the conditions where we observe a great number of diagnostic errors. There can be different types of diagnostic errors, and we can usually roughly group them into 3 types: missed or delayed diagnosis, a wrong diagnosis, or a diagnosis not acted upon timely. These errors are often errors of omission, which mean that they can be difficult to capture through incident reporting systems, as sometimes there's no clearly defined point of error, and they can also be difficult to find in a patient record audit if you audit care episodes only. Because, in the domain of high reliability, we typically the errors we typically see is failure to recognize a pattern. An example could be early signs of sepsis, but it could also be an instance of tunnel vision, where you focus so hard on one problem that you miss clues that something else is going on too. A classical example of this could be a patient with dyspnea who comes to a pulmonary medicine unit, and they are so obsessed with finding a pulmonary reason for the problem that they too late realize that this is really a cardiac problem. We also have some diagnostic errors that should be actually in the domain of ultra-safe care, and that's where an error is due to a broken information chain. The information is there, but it doesn't arrive at the person who needs it, as opposed to the first type of errors where the information is there, but the significance is not realized. And we can illustrate this with a couple of stories. I owe this vignette to Sir Liam Donaldson, who is a safety ambassador for the WHO, and he presented it at the recent WHO Global Ministerial Summit in Chile. A case of sepsis, patient died. The family, she would still be alive if they'd listened. We felt and we were convinced that something was wrong, but no one listened, no one reacted until it was too late. The story was investigated by perhaps a investigator team, and they identified 15 factors that contributed to causes the harm. That's what I told you about, factors colluding to create a dangerous pattern. And the clinical team said, well, the hospital was completely overloaded that day, and we hardly had any time to reflect on what we were doing. And all of these perspectives are right, and how can we find a way to avoid this from happening? Of course, the vigilance and the ability to recall and recognize patterns is one of the core competencies of a skilled professional. But here I would say that a well-functioning team of skilled professionals has a higher potence than the skills of one professional. It's very important to have a team culture where everyone in the team is empowered and feels safe in speaking up if he or she thinks that something is not as it should be, is, if you like, and monitoring in the monitoring stage of the resilience cycle. And the team should include the patient and family as part of the team as well. We could support the team by giving them tools such as early warning scores, and artificial intelligence may in the future, or is even now perhaps able to recognize patterns and suggest, look, this might be an early sepsis. And as witnessed by the perspective of the team, general measures to improve working conditions will also contribute to preventing this from happening again. And training of teams through simulation is a very powerful tool. If you do a team simulation, it's my experience that you very soon forget that this is a simulation. You become very actual, engaged, and as if it was the real thing. It allows you to train procedures that you are not expected to be using very often, such as, for instance, a difficult intubation, to go back to to something from my own previous specialty, anesthesia. But team training is not only a question of training technical competences, is at least as much a question about training team competence, being able to listen, being able to create a common understanding of the situation across the team, with everyone contributing, everyone listening, and everyone using the power of the entire team to anticipate and monitor and find the right response. Yeah, summarize it. The power of the team is that it can create a common situational awareness that continuously updated. In the history of aviation, we heard of situations where this failed. There are recordings from black boxes from crashed airplanes where you can hear the first officer trying to tell the captain that something is really wrong, but can't cross or make himself break the barrier of the hierarchy and the authority of the captain. The team can also contribute by never taking assumptions for granted, listen to others, be attentive to signals, have a very good toolbox of trained options, and to improve their skills, they must also be empowered to respond, to take the actions they need to take, and they must be able to take the time to debrief and learn. Of course, there are some pitfalls. I already talked to you about power hierarchies that who can have devastating consequences, but you must also be mindful of the risk for groupthink, which is the opposite of creating a rich situational awareness, that you confirm each other's that you are still in your comfort zone. A good example of this is when the fire alarm sounds, everyone looks to everyone else in the room. I won't make a fool of myself by reacting if they don't think it's something important. There are other errors that should never happen. This one, no one noticed that the blood sample never reached the laboratory. The hospital's procedure of double-reading mammograms examined by doctors in training was not adhered to systematically, and the suspect nodule that was not detected by a junior doctor was missed. There was an INR value that was dangerously high, and it was marked as such, but no one in the ward noticed until 3 hours later. And there was a pathology report sent to a physician who had requested them. A physician was on long-term sick leave, and the report of a malignant melanoma sent to him was not seen by anyone until 3 months later. I would consider that, or suggest that you consider these errors to be never events, just as wrong side surgery. Normally, we think of never events as very serious events, such as amputating the wrong leg, but these are errors that could be avoided and should not happen. Most of these events will probably not have serious consequences, but the potential is there. And if you encounter any near misses of these types of error, count it as a blessing that this happened without any serious harm, because this is a golden opportunity that to examine your processes and try to create processes that are really ultra safe, as should be the case in this type of processes. And we make, of course, the ultra safe domain ultra safe by having standardized processes that are designed and standardized, supported by human factor insight. We know what types of errors people are likely to make, and we design our systems in ways to avoid making these mistakes. We analyze the process to identify and correct error options, and we improve based on experience. Finally, a few words on how to promote process standardization. And here's a list of ways to do it. The top ones are most system-focused, more effective. The bottom ones are more people-focused, less effective. Forcing functions is not possible to do the wrong thing. The classical experience, again drawing from my drawing from my experience as an anesthesiologist, is that you can't connect the oxygen tube to the nitrous oxide outflow because the couplings won't fit. That's the forcing function. It's very effective. You don't have to rely on people remembering the right thing. They can't do anything but the right thing. But of course, you can't standardize everything that way, but you can use automatization, computerization, simplification. Simplification is actually a very good idea. Try to make things more simple, not more complex when you improve them. Reminders, checklists, double checks integrated as part of the workflow. Rules and policies have their place, as well as do education and training. You you should, of course, not because rules and education are low in this hierarchy, you shouldn't believe that they are not important, but their place is more perhaps, and that goes especially for education and training, to have to train the ability to, again, I come back to this again and again, anticipate and monitor, have a good toolbox for responses. So with this, I conclude for now. And on this slide, I'll just show you a few ways in which you can connect with ISQua. And I'm happy to take some questions or some comments if anyone has anything to bring up with me now. But thank you for your attention. I'll stop sharing my slides now.
Thanks, Dr. Carsten. I am Dr. Abdurrahman. I am the deputy of the medical director of the hospital. I'm responsible for surgery department and endoscopy unit and anesthesia team. We will open for questions if any of the participants would like to ask questions. And our team here will arrange some questions for you. Thanks for your fruitful presentation.
Thank you.
Hello, Dr.
Sorry, I don't hear you.
الصوت مش واضح عند حضرتك كده.
Dear doctor, we need more information about the fellowship.
Yes. Well, the fellowship is a series of, at presently, we have 9 courses, and they cover broadly the aspects of quality and safety in healthcare delivery. Each course has approximately 6 webinars of about 45. Each webinar of about 45 minutes. And so the idea is that you listen to a series of webinars and you answer some multiple choice question after each webinar to assess whether you captured the content. There are some case studies that you can upload to a forum where they can be commented on by your fellow learners. There are some selected publications for you to read, again with multiple choice questions. This one course is designed to be completed within something like 25 or 30 hours of learning. If you complete 2 courses per year, in the first, or if you complete 2 courses in the first year, you can call yourself an ISQua fellow, and you can renew this fellowship annually by completing 1 course or by attending the ISQua conference or some other selected major international conferences. So in this way, we try to make the fellowship a community of learning, a community of learners. And we will add
Dear doctor, can you unmute?
Yes. Okay.
Yes, it's okay.
So I explained briefly to you the structure of the fellowship. As an ISQua fellow, if you sign up for as an individual member of the ISQua fellowship, you will be a member of ISQua as well, with the benefits that you get as an ISQua member. If a hospital or any other organization becomes an institutional member, they can sign up a group of their staff or anyone else at a discounted rate.
How many to get a discount?
Sorry?
How many candidates should apply from our hospital to get a discounted rate?
I believe it's 10.
10. Okay. Yeah. And if more than 10, is the discount is more?
If you have, we have a few very large groups, and we might be able to negotiate special discounts for them, but we would have to decide that on a case-by-case basis.
Okay. Then we have 9 courses. The candidate can select 2 of them, and then
yes, and
2 of them every year, and he can complete them by like 5 years.
Yes, and you
Okay.
I mean, you can if you wish, and if you have the time, you can complete all of them in 1 year. But the idea is that we want to support an ongoing learning journey, and we will from year to year add new courses. This year, as I told you, we'll add courses on sustainability and artificial intelligence, and the aim is to add or renew 2 courses annually, so that there always will be new content.
Every course is 6 webinars, and then the candidate can take like a webinar a week.
Yes, you can do it. You can do it in the pace that suits yourself. You can. The only requirement is that you complete your curriculum within 1 year.
Yeah. Okay. Let's. Okay. Now, any of the audience have questions, please raise hand. Yeah. Okay. Can you, Dr. Abdullah, can you say your question? Dr. Abdullah, you have raised your hand. Can you tell your question? Okay. Is there any other questions from the audience? Professor Khaled Mustafa, please tell your input or question.
I am very grateful to this great lecture. It gives us many new information and was very helpful for us. I have one question about the balance between patient safety and the patient satisfaction, because this is a culture. Does the ISQua help us to generate this culture to make the priority for the patient safety?
And it was the patient safety versus patient satisfaction?
Yes.
Well, actually, we don't see that there we don't see that there really is a or there needs not be a conflict between those two. We have coined a concept we call person-centered care, and we have a white paper on person-centered care that is freely available on our website. And one of the messages is that first, the patients have another perspective of the care journey than the professionals. So when you bring these two together, you will understand the system better and will be able to find improvement opportunities. The patient sometimes sees things that you don't see. Of course, we can't let patient requests compromise patient safety. So person-centeredness doesn't mean that the patient necessarily has everything in his way. It means that the patient is a partner with whom we discuss and find the right thing to do based on we call it based on what matters to you from the patient's perspective and what is possible from a professional point of view and with the resources we have from your perspective.
Great thanks for you. Great thanks.
Dr. Abdullah, can you tell us what your input? دكتور عبد الله ممكن تكتب لنا في الكويشنز دكتور علياء اتفضلي. دكتور علياء, can you speak? Dr. Engel, Dr. Aliya has asked how many institutes in the Middle East have this system.
Which system are you referring to?
I have a comment from Dr. Samia. Thanks to the conference, I hope strong networks could be created to reinforce diagnosis capacities.
Thank you. Yeah, that's what we aim for the conference, to be a place to get together, to meet colleagues, exchange ideas.
Maybe this idea need more elaboration from you. Can we create local and regional networks? To share knowledge, to share experiences, and under the umbrella of the ISQua?
Under the umbrella of ISQua, well, we we do establish something we call communities of practice, where a group of, to establish a community of practice, we need a nucleus of ISQua members who take on them to be a kind of steering group for these community of practice. They will then identify topics of interest, and we will try to find from our network of expert speakers to speak to this community, and they can then arrange for discussion sessions among themselves, and we can facilitate with infrastructure for that. Actually, at the moment, there is a community of practice for Africa under establishment. We don't have any communities that are specifically for the Middle East at the moment, but we have members in many countries in the Middle East, including, for instance, just to mention some Jordan, Saudi Arabia, some of the Gulf states. And if you are a member, you will know about each other's, and you can contact yourself and establish your own informal network based on your mutual membership of ISQua.
There is a question about how can we record this presentation of and share it with the audiences?
Yes, you can. You're welcome.
Thanks very much. So for the audience, we will share it soon according to your attendance. Dr. Abdullah couldn't speak to us. Then he sent a message. Thank you very much for the presentation, Dr. Carsten, and thanks for Shefa Hospital for this opportunity. I have a question about the 800,000 medical errors in USA. Are these errors avoidable? If yes, if we compare these errors with IOM report in 1999, this is a huge increase. So where is all the efforts to decrease those errors?
Yeah, it's a very good question, and I wondered about these numbers myself. I think some of the ideas is that if you do a journal record to look for adverse events, you might miss some of these diagnostic errors because they are errors of omission, and as such may go undetected. But there may also be some issues with the precise definitions of and the methodologies used. But I think there's no doubt that diagnostic error is a huge problem, and I would say that in principle, at least, errors such as failure to detect a sepsis early, failure to detect a cancer on a mammogram, missing a lung cancer, which was one of the big sources where these should, in principle, be avoidable. We should at least not. We should not satisfy ourselves well we couldn't have done anything about it.
I have a comment from Dr. Samia. I hope there are possibilities to develop diagnosis kits for research, or a research on developing diagnosis kits.
Yes, obviously there are, and if you look to WHO, for instance, they do a lot of work this year to promote diagnostic safety, including, of course, developing or not developing, but giving access to the best science in the area.
I think this is great. We have enjoyed the presentation, and we look forward to more communication with your esteemed self. And I hope we can develop a nucleus here in Shefa Al-Orman and build a network with your advice and assistance. I like to thank you very much, Dr. Engel, and I think we can conclude as of your time of precious time. Thank you very much.
Thank you, and I enjoyed being with you today, and I hope we will meet and discuss again in the future. We share the same ambitions for quality and safety.
Thank you very much.